So our final session of the day will be on hemodialysis and its application to real-world research and medical practice. It will be given by Dr. Yu, who's Assistant Professor of Surgery at the University of Pittsburgh, and his research interests revolve around outcomes in end-stage renal disease patients with optimizing hemodialysis access. So, welcome, Dr. Yu.
Thanks everybody for sticking it out here for the last session of the day. All right, here's my disclosure. I am a consultant. So quick agenda here. Let's talk a little bit about the inclusion and exclusion criteria. Any autogenous or arteriovenous fistula and prosthetic grafts. This includes fistulas using transposed veins and AV grafts using prosthetic or biological material. Also include AV access performed using open or endovascular techniques. This is a reference to the percutaneous AV fistulas. I'm not going to talk about that too much on this go around though. Just note also that the second stage of a hemodialysis access procedure, typically a basilic vein transposition, sometimes a cephalic vein transposition, should be captured on the follow-up form for the original procedure. So some exclusions. All dialysis catheters are excluded, which is actually kind of a big deal because it turns out that most patients start dialysis with a catheter, but many times these are performed by sometimes nephrologists or radiologists, and so vascular surgeons are not typically the ones placing these. Any thrombectomy or revision of an existing access, that's supposed to be captured on our follow-up forms, though I will kind of mention at the end that there's a bit of a weakness to that. Any percutaneous thrombectomy or angioplasty or stenting of existing access, this again is not a new procedure, it's actually a follow-up, and so if that's being performed on a access that was built by somebody else that is not captured in VQI. And any other, in the same vein, any kind of surgical revision like a drill or other procedure performed for ischemia is also captured ideally in the follow-up form and is not a new procedure. Some of the key history elements, you want to be able to capture what previous surgeries, what previous accesses they have. This is typically quite important to understand the risk factors for failure of a fistula. Typically, patients who have had other failed surgeries in the past will be at higher risk for failure in the future as well. Again, other additional key history elements, what other catheters or devices do they have? Of great importance to many of these patients is the presence of a central venous device. Anytime you have a piece of plastic or metal inside somebody's chest, the patient's veins typically don't like that, and their response is to scar down. This can lead to rather bothersome swelling, or actually quite debilitating swelling, and is definitely an indication of a more challenged patient. Similarly, a lower extremity tunneled catheter is also a very bad sign, but we should be able to capture that in the preoperative history elements in order to really kind of get a better sense for their risk adjustment going forward. Also, some of the other more exotic accesses, sometimes people have a transhepatic catheter, a translumbar catheter, or in at least a few cases, an axillary to axillary graft. If these are present, this should be captured because it does represent a higher risk patient. A little bit about anatomy and physiology. This is the classic radiocephalic fistula there on screen left. That's the black and white photo is a picture from the first presentation of this, the Brescia Semino Appel fistula. And on screen right, you can see actually one of my patients from several years ago, which is essentially the same surgery, slightly different geometry and suture material, but the same basic concept. On the top, you can see what this looks like on the wrist. That's typically what you see at the radiocephalic fistula at the wrist. And on the right, you can see what looks like a typical brachiocephalic AV fistula. I spoke briefly before about transpositions. So sometimes when people create a fistula, the venous outflow is the basilic vein. This is many times a very nice vein. It is a protected conduit. Sometimes the cephalic vein, which is a little easier to use, has been diseased or has been used up, frankly, by venipunctures over many years. And so it's actually not usable for dialysis, but the basilic vein is sometimes a better choice. However, it's inconveniently located, and so you can see on the second stage that it needs to be transposed. This is an intraoperative photo of what that may look like. It's a very large incision, which can be a little bit cosmetically disfiguring, but if it leads to a good access, then many times it's considered acceptable. Again, this second stage is considered a follow-up to the initial surgery and is not captured by itself. The AV graft is the other main surgery that we capture. This is basically a connection, again, between an artery and a vein, but instead of being a direct connection, there is a piece of prosthetic between the two vessels. These geometries are kind of limited only by your imagination to some extent, but in practice, there are really only a few that we use. Typically, the loop there in B, the brachial artery to axillary vein graft in C, or sometimes the thigh graft there in the lower right-hand corner. Pre-op, we do actually ask that we get some information. Actually, sometimes we get an arteriogram or a venogram to determine if there's problems that preclude use of one particular extremity. For an AV access, on the screen left, you can see an arteriogram. It's a little difficult to interpret here, but it does turn out this represents a brachial artery occlusion there at the antecubital fossa. You can see the elbow there. And this was related to a previous surgery that the patient had at that arm. Sometimes when you have this indicates that you probably shouldn't go to that arm, though occasionally it can be revascularized for use for AV access. And on the right, you can see a venogram. This is a patient with a central venous occlusion. This is, in my practice at least, fairly frequently used in order to determine if a central venous occlusion or stenosis exists. And this will many times affect my choice of AV access, and many times will lead to the use of a HERO system, which we'll talk about. But this is something that does show up in the pre-op portion of the module, and if you see this, please record it. This is the HERO system I just spoke about earlier. This is a combination catheter and graft system, which gets around that blockage there deep inside the chest. In this, there's a PTFE graft that's coupled to a nitinol venous outflow component, which goes into the chest, as you can see there. This is usually used as a last resort before catheter dependence or as an alternative to a thigh graft. If anybody's here Friday morning, we're presenting some of our own data regarding use of the HERO. The standard PTFE graft can be cut out and replaced with a different graft. This is an option when the HERO system is chosen as the axis of interest in the VQI. There's also a super HERO adapter, which enables use of a different surgeon-specified graft, and I believe that's also part of the module as well. One of the other questions fairly recently, in the most up-to-date version of the module, we did ask that we capture information about the intraoperative anastomosis length. And the reason for this is because with the advent of some of the newer technologies that advertise actually very defined arteriotomy and venotomy lengths, I thought it was important to include that as part of the surgical assessment as well. What I asked is that we actually measure how long the anastomosis is and capture this in the VQI. And in this case, using a ruler is actually very helpful. Now, to be clear, it's also very difficult to get anything more accurate than a millimeter. So it's a little bit unrealistic to ask for, say, a 2.5 or 2.6 millimeter anastomosis. In reality, it's usually some sort of integer value. And here's another example of what these look like in real life. And here's a little cartoon of what this may end up looking like, just to be clear about what length we're asking people to capture. Long-term follow-up, post-procedure interventions are frequent and really should be recorded. And this is where it is recorded here in the long-term follow-up down there on the bottom. And this is an example of what this looks like intraoperatively. This is a fistulogram. This is actually at the wrist. Actually a snuff box, and the artery, you can see is that middle line there that runs off to the right side of the screen, and the vein is higher up, and if you look very closely, you can see that there's a stenosis there between the artery and the vein, and this did require a balloon angioplasty. Again, this is something that can be recorded in the long-term follow-up, which is quite valuable for us. And that's captured here in the post-procedure intervention screen. If a stent is used, we have included the Good ID system. And so this is something that we can capture exactly which product that was used. I don't know if anybody's been using this and had success. I've not heard any issues with it, but certainly if there are, please bring them to our attention. And I just want to spend kind of the last few minutes here talking about the fact that, there's been a lot of work. You guys put a lot of work into putting together all this data. And it's kind of interesting, I think, to know on the back end, like what happens to all this data. And this data does create the bedrock for sometimes very important advances in knowledge. In certain cases will hopefully change practice. But here's one example of this. This was a publication just published earlier this year that characterized the long-term survival in Medicare patients. This is a fusion of VQI data, which is really quite excellent for capturing intraprocedural information. Really, there are no other databases that I'm aware of that can capture this volume of information on such a granular level. One of the challenges, though, of VQI is actually that long-term follow-up. Certainly, we look forward to having your teams help us with populating that, but it can be hard. And so alternative places where we can get that data we've explored. One of them is something called the Vision database. I don't know if we talked about that too much here yet, but that's a FDA-sponsored database, which also includes quite a bit of Medicare information. And so this was a fusion of the VQI data with the Vision database, which I think leverages the strengths of both databases. The VQI very good for perioperative information, and the Vision database being great for long-term information. Now, this particular outcome was mostly just mortality. Mortality, of course, being a very important outcome, though in some cases maybe not the most important one for dialysis access. But this was some of the survival curves that were created based on this. This demonstrates that patients who undergo fistulas actually have better mortality rates than grafts, though interestingly, the separation of those curves is not as big as sometimes you would think. And then also it's to generate some risk assessments about the different risk characteristics that can lead to increased mortality or less mortality. Here's another publication that was actually very important. This was named Editor's Choice, Temporal Trends in Hemodialysis Access Creation During the Fistula First Era. This again used VQI data, and it demonstrates that despite lots of effort to try to create more fistulas during the time that this was popular, nothing really changed very much, which was a little bit disheartening. But it's still important to know. It is also important to recognize in there that it did identify some disparities in care. You can see that one of their findings was actually that typically underserved populations were, of course, less likely to receive a fistula and more likely to receive a graft, which is an area that deserves quite a bit of research to understand why that exactly is happening. One of the other comments here is that femoral grafts are sometimes used. I touched on that briefly in the context of the HERO system. We know, or at least we believe many times, that femoral grafts are bad. But it's always important to not just state that with just some expert telling you about this. It's more important to have some sort of data. And here's some of that data here, coming from the VQI, demonstrating that lower extremity dialysis access patients really have poor primary patency and survival. Again, seems like kind of a rather simple message, but it's one thing to have somebody state it, and it's another thing to have thousands of patients to back up the point. Another important topic, and hopefully this is a quality improvement measure, is that preoperative vein mapping is associated with improved outcomes. And so this, again, VQI analysis looked at patients who did have vein mapping and who did not have vein mapping. And certainly the patients who had the vein mapping did better. This is perhaps a good justification for why getting this vein mapping is important. And as somebody who's in practice right now and struggling with the fact that vascular technician time comes at a premium, for me it's actually very difficult to get all my patients vein mapping because the schedules just aren't set up appropriately for that. But papers like this allow us the research background or the research bedrock to help us justify why potentially a rather large investment of technician time can lead to important and improved outcomes. So, kind of a relatively quick presentation, hopefully get us out a little bit faster than we would have expected. But I just want to kind of reiterate, the VQI hemodialysis access module, it's a fair amount of work, but this is really important information, and it can lead to practice-changing research. And I just want to say, I don't know if anybody said this, but thank you. Thank you to all of the people throughout the country who are collecting this data. I certainly feel a debt of gratitude to all the data abstractors and the sites that are dedicated to the Vascular Quality Initiative and, of course, our hemodialysis access module. So thank you very much, and I'm open to have any questions.
Well said.
Thank you for this presentation. I just actually wanted to sincerely thank you for highlighting the publications that have come from the data that we're collecting in this registry, because it is quite a lot of work. I was abstracting a long-term follow-up for a hemodialysis patient last week, and he literally had 7 re-interventions. And I found myself
Typical.
thinking, like, why am I
Typical.
doing this? Will anybody care? Will anybody look at this? And so this has really spoken to me, so thank you.
Thank you so much.
It speaks to outcomes and why we do quality work.
Right.
And it's wonderful. I have a question, just real quick. When you talk about preoperative vein mapping, you're talking about vein mapping prior to entering the procedure, the operative procedure room?
Yes, and so
Okay.
that's actually that's I think as we currently have it defined, and that's actually kind of an interesting point because I was just looking at our own VQI data. In fact, there is a surgeon in our group who does not use very much preoperative vein mapping, and that's me. So I need to ask my chief to get a little more technician time for me. Yeah, so it definitely helps. Interestingly, I gotta say in my particular case, I do a lot of my vein mapping. I mean, I vein map everybody. I actually have my own little pocket ultrasound that I carry around. This is, I believe my outcomes are pretty good, though, we have to do, I think, a more formal analysis about that. But certainly it would improve our workflow if we had more of that formal preoperative vein mapping. But yes, that's definitely one of the quality improvement initiatives that's kind of looking around in the back of my head.
Do you see better longevity between fistulas or grafts?
So yes, so I mean the data would suggest pretty strongly that fistulas, when they work, tend to work better. Though there is a bit of a selection bias because the patients who get fistulas tend to get fistulas because they have better anatomy, and so there's a bit of a circularity to that. In the patients who do not have good anatomy for fistulas, then it seems like the graft is probably the better choice. But in those patients, you probably wouldn't even try a fistula because the veins are just so terrible to start with. Is that then the fault of the graft that things aren't great, or is that maybe just again a reflection of the fact that the patients, that the substrate that you're working with is perhaps more challenged? Now, there are studies. In fact, again, we actually just ran a study in which we randomized elderly patients, both fistula and to graft, patients who were potentially good candidates for a fistula even. And although the outcomes were better short term in terms of getting a graft, it turned out that long term was only measured at a year, they actually had similar outcomes. And presumably, if you extended that out beyond just a year, you'd have potentially better outcomes with the fistulas. Though, of course, in the elderly patients, you don't know whether or not they're going to live long enough to benefit from the long-term benefits. But certainly at a year, we found quite similar outcomes.
Well, Ted, you showed the slide that the Fistula First initiative wasn't really very successful, but at the same time, the DOKI guidelines removed
Right.
that recommendation, so maybe providers were ahead of the game.
So that's, I've also been impressed over the last, I guess I've been in medicine now almost 20 years. Just there was a bit of a pendulum swing, I feel like, between how physicians think about different ways of treating patients. So certainly back in the 1990s, grafts were very popular. Certainly they seemed to be very quick to use. But then there's the concern that this was associated with high costs. And so in the early 2000s, there was this Fistula First initiative. And that was really kind of the operative guideline, the operative paradigm for 15 years. Through my training, it was Fistula First, Fistula First. But then we discovered that there was quite a few fistulas that just weren't working very well. Now, interestingly, it doesn't really show up that much in the data, but certainly from a clinical perspective, we saw lots of failed fistulas. And so around 2019, with the latest version of the KDOQI guidelines, so version in 2006 talked about fistula first, and then finally 2019, 13 years later, they said, well, it should be optimized, or it should be kind of tailored to the patient in front of you. And so fistula first was taken out. So yes, to Jens's point here, maybe the physicians were right not to be swinging along the pendulum so fast. Yes.
This is a question more on the analysis side of the dialysis registry. So, I've received data from VQI and outside of our own center. In terms of the instructions that are given, it would suggest that primary patency may not be easily interpreted from the data. Primary assisted patency, okay, but maybe not that great, but secondary patency is pretty good in terms of well interpreted by the data. Are there things, or have there been changes, or are there changes to the data registry that maybe could improve that over time? Or what are your thoughts on that?
So I think this kind of goes back to the idea of what VQI is really good for. VQI, I think, is really good for getting perioperative or peri-procedural information. There's nowhere else in vascular surgery that I'm aware of where you can get this level of granular detail about, artery size, anastomosis length. USRDS exists, which has very granular, I think, outpatient and follow-up data. So if you want to know whether or not a fistula is used on a month-by-month basis, they have that data in USRDS. It would be unrealistic to ask our data abstractors here to call each dialysis unit for each patient and find out whether or not the fistula is being used. Show of hands, anybody interested in making those phone calls? Anybody? Zero? Nobody? Yeah. So this is where fusions with other data sets can be very helpful. And so I'm sure many of you guys know Dr. Karen Wu. She's actually gone through the effort of trying to now merge some of the USRDS data to VQI, which I'm hopeful will actually give a kind of a more holistic view of this entire process. The only downside there is that the data lag between getting data in and being able to use it for USRDS is like 3 or 4 years. And so the most recent information we're going to have is actually probably even longer, 2019, so it's be like 5+ years. Presumably physiology doesn't change that much over 5 years, so perhaps the lessons learned will be helpful. But in terms of actually getting like kind of daily dashboard updates of what's your fistula maturation rate for your last 6 months, I would love, perhaps this is a brainstorming exercise in which we could figure out some better solution to get kind of more up-to-date information. But yeah, that is a holy grail that I would love to go on a quest for.
Yeah, no, I was just going to say very briefly, I think that's spot on. I use a lot of vision data with other data set or other registries, and vision data is very powerful, but I think for this particular registry, there needs to be an addition of USRDS data.
Yeah.
So on this topic that you're talking about, there's a question. Do you have any suggestions on how to obtain the first access date? Because it's needed for long-term follow-up, is for the compliance, but it's rarely documented.
Yes. So this is a challenge. Now, I don't think it would be realistic or appropriate for the data abstractors to call the dialysis units, and so they're kind of the challenge there is you have to go into the medical records, the office records, and see whether or not that's been documented anywhere. And sometimes you just don't know, and that's just the nature of the follow-up. Yes, this is a longer-term challenge, and if we have great solutions for that, I'd love to hear it.
Just one quick solution to that. So in private practice, it's easy because we mark the patients and give them an okay to use. So when the patients come back, we ask them and verify that. So we are lucky there.
Do you have them come back? Like, how many times do you have them come back after you operate on them?
We usually just have them come back for a 4-week duplex, check the flow rates, double check, see how things are working, stuff like that.
Do you find out after you clear it for use, do you find that they actually use it? Because I've actually found that it's like 50-50 whether or not it actually ends up getting used, even despite being told that it's okay.
Most do, but at least in our area, there's a high number of catheter used before we get them, so we want to pull those catheters out right away. So again, that 2 to 4 week window usually is perfect for that.
And do you take out the catheters too, or do you end up
Yes.
having other people? Okay.
Yeah.
Well, that's a good way of to me, that's the ultimate sign that the fistula is usable when somebody pulls out the catheter.
My real comment, though, is just thank you for the one data set. we vein map every patient before surgery. And I don't know, just again, a brief comment to you. Multiple insurance companies fail our prior auths because the only indication is for cabbage. So hopefully we can change some of that down the road, but we have to do peer-to-peer reviews all of the time for those.
Oh, so you don't get reimbursed for the vein mapping at all?
Well, again, it's a prior authorization, so we want to be authorized before the patient comes in. And it requires, I'm a PA or one of our doctors to get on and do a peer-to-peer review for, and again, it's multiple insurance companies.
Well, there's your paper, so.
Thank you.
So we have a question, are trilumen dialysis catheters categorized as central venous dialysis catheters?
Yeah, so a trialysis catheter is definitely a central venous catheter. I'm not sure which slide it is back here, but I'm having a little trouble seeing it. Let me see here. Yes, a trialysis catheter. Now that's a temporary catheter. It's not a tunneled catheter. Right. So yeah. So this would be catheter. So one of these would be yes. Previous other catheter, yes, and so there would be something in the chest, presumably at some point. Probably previous right or left. Probably right.
Okay. On average, how many post-op interventions are HD access patients requiring, looking for a benchmark for our facility's numbers?
Haha. So for grafts, so we actually published on this, but for grafts, it's 0. So the number of interventions you should have before use of a graft is 0. And in fact, each additional intervention you have is relatively rare, but is definitely associated with much lower rates of functional usage. For fistulas, the number is probably around 2. It's even with surgical fistulas, which is surprisingly high. Now, there is obviously a distribution. Some of the fistulas do great. They don't require any interventions. Some of the fistulas just require 1. But there's a fairly long tail of 2, 3, 4, 5 procedures required to obtain functional patency. Now, to be clear, these are surgical fistulas. I'm not even talking about endovascular fistulas, which typically require many more. So for that benchmarking, it's a little interesting because you have to recognize that there is going to be a curve there. And the patients with the best anatomy, the patient with like the 4 millimeter cephalic vein at the wrist, and usually a guy, frankly, with a big artery, this person is rare, but that patient will also probably not require any interventions. The more typical population that I end up having is somebody who's a little heftier, perhaps, smaller vessels. That patient will require, at least for me, and I think for many others, probably 2 or 3 interventions to get the vein to be big enough to be used.
Okay. Is there a recommendation for patients to try CAPD for dialysis prior to moving into hemodialysis? If a patient does need to move into hemodialysis, does the length of time the patient is on CAPD affect the successfulness of the AV fistula maturing?
That's an interesting research topic. So I am not aware of any particular guidelines regarding the effect, or at least publications talking about CAPD leading and then subsequent AV fistula usage, though of course this is something I see quite a bit. For those who don't know, CAPD is continuous ambulatory peritoneal dialysis, which basically just means putting a peritoneal dialysis catheter into your body, filling yourself up with a gallon of glucose, water, or starch, and then dialyzing through the miracle of osmosis. There are guidelines that do suggest that patients should be trying peritoneal dialysis instead of hemodialysis, and this is something that we definitely encourage patients to do. The reality, though, is that for many patients, getting peritoneal dialysis is a bit of a hard stretch. That bag that I was talking about is at least 10 pounds, and you need multiple bags per week, multiple bags sometimes per day, and it literally shows up as a ton of sugar water showing up on a pallet at your door. And so from a practical perspective, although it is possible to get training to do peritoneal dialysis, you need to be a fairly functional person to do this. You also need to have the manual dexterity to use lure locks and various other things. And you also need to have a very clean environment. If you get a cat into one of these bags of sugar water, it's a disaster. While we definitely try to encourage patients to get peritoneal dialysis if possible, a lot of patients just aren't really good candidates for that. And again, whether or not that affects their ability to get hemodialysis later on, I am not aware of that particular analysis being done, but certainly it is something that is worth probably looking into.
Okay, this person has a lot of patients who do not use their fistulas because they have a phobia of needles and don't want, and didn't know it would hurt, and they forget to do the exercises. If you have a patient referred to you by nephrology that expresses a needle phobia, do you go ahead and create the fistula, or do you send them back to nephrology?
So two things. Has anybody actually seen the dialysis needles? Show of hands, right? Are they big? They're enormous. Who's given blood,
Yeah, they're huge.
right? They're the same size as the blood donation needles, but that's only like one needle when you donate blood. Imagine getting stuck by those things 2 times, sometimes 3 times in one session, and then having to do it 3 times a week. I'm afraid of the needles. I mean, they're crazy. I mean, I've never even had surgery. It's kind of a crazy thought to me to like have one of these things stuck into my body. So first of all, I just want to say that I think we should have sympathy for the patients. Needle phobia is a real thing, and I think, frankly, we all have needle phobia. Now, are people willing to tolerate this? Well, many times they are, because I tell them that if they don't use the fistula and you're stuck with a catheter, you're at increased rates of infection and death, and death is very motivating. But this is kind of, I think, outside. This is clearly outside of the QI question. But I would just say that this is something where you got to talk to the patient, and in certain cases, you got to maybe even go to the dialysis unit and show them this is something that's potentially going to be is going to be tolerable. There are creams that can be placed onto the skin to make it more tolerable, but ultimately these are 15 gauge needles, and they're long. They're 1 inch long, and unless the fistula is also built well, it will hurt, and there could be missed cannulations. So I guess to answer that question, I mean, in my practice, I definitely still do it, but we also have long conversations and try to make this as easy and as painless as possible, but still recognizing that it's never going to be completely pain-free.
Yeah, I'd echo those comments. It is a lifestyle choice that they need to make as well. A lot of that is denial about their kidney disease, and in front of that. So there's a tremendous amount of psychological benefit to educating them, but more importantly, to have them visit a dialysis unit prior to intervention, because they'll see that a dialysis unit is a family, and they become adopted into that family, and it becomes much more accepting to them. So needle phobia seems to fade away when you realize all those other factors that are necessary for them if they're not a kidney transplant patient, and other alternatives for dialysis are exhausted from that.
Okay, and our last question so far, do you know what the average number of interventions after the HD access has been used up to 21 months long-term follow-up date?
In the VQI, no, but perhaps I'll ask Carolyn for that report. This will be an underestimate, though, because clearly I fully understand that we're not going to capture every single fistulogram that is performed on these patients. However, I will say that other studies have suggested that it can be, again, there's a distribution. Some patients get a lot of interventions each year. Many patients get 0. And that is something that is captured in the USRDS, and we've published on this as well. But the guidelines actually have a recommendation. So the latest 2019 KDOQI guidelines talk about 3 interventions per year to maintain patency. To be clear, when I talked to the author about this, I asked her where she got that number, and it was kind of expert opinion. So that's a place where having additional data will be helpful for us. But yeah, so the guidelines currently articulate a 3 interventions per year maximum number in order to maintain patency. That's what we would expect, though many, I think, would get less than that, or should get less than that, frankly.
So then there's just a comment, the most interventions we had on a single AV graft at the time of follow-up is 7. So that's there.
Yeah, presumably, I don't know, if that's over a year, I think that's probably too many. That's an indication that something needs to be rethought. But if that's over 2 years, that's actually pretty reasonable. That's kind of par for the course.
All right, Ted, thank you very much.
Thank you, Nancy.